Each MyEMCert module will include content based on key advances to the practice of emergency medicine. M.B.A made this video for you to emphasize one of those advances. Key advances will highlight emerging practices, diagnostic modalities, and patient management strategies incompletely adopted into clinical practice. Some might seem very familiar to you, or they will help to speed up knowledge translation of a recent advance that may be quickly incorporated into your practice. From time to time, M.B.A will send you a video to focus on a key advance in our specialty. This video is intended to be a resource for M.B.A certified physicians to review a key advance topic that may be included in your MyEMCert modules. Though there will be 3 to 6 key advances introduced each year, many will not be emphasized with a video like this one. Check M.B.A.'s website for additional key advance resources, including synopses for each advance. Now let's take a closer look at the key advance topic, oxygen for myocardial infarction. A middle-aged man presents to the emergency department with severe chest pain lasting for 1 hour that has not resolved with rest. His blood pressure is 130/70, heart rate is 96 beats per minute, and oxygen saturation is 99% on room air with no signs of respiratory distress. The electrocardiogram shows ST elevation in leads 2, 3, and AVF, suggesting an inferior wall STEMI. The nurse immediately puts the patient on supplemental oxygen by face mask and administers an aspirin. Historically, it has been common clinical practice to administer supplemental oxygen to any patient presenting to the emergency department with a suspected myocardial infarction, irrespective of their oxygen saturation. The logic behind this has been that supplemental oxygen would improve oxygen delivery to the ischemic heart tissue, thereby reducing myocardial injury. But this conventional thinking is being challenged by evidence-based observational studies and clinical trials. These studies have demonstrated that supplemental oxygen may not improve outcomes in a myocardial infarction patient with adequate oxygen saturation. Hyperoxia may cause secondary injury due to coronary artery vasoconstriction. This results in free radicals, which increase inflammation, leading to reperfusion injury, as well as constriction of other major arteries, increasing blood pressure, and by extension, increasing afterload of the already ischemic heart. These potential harmful effects have not been conclusively proven, but data suggests best practice is to avoid empiric oxygen. With this new evidence, a clinical practice change has been recommended. The recommended action is to avoid routine supplemental oxygen therapy in suspected myocardial infarction patients unless the individual is hypoxic or in respiratory distress and oxygen saturation is lower than 90%. As a quick recap, recent studies have shown that excess oxygen does not improve outcomes and may cause harm. Current recommendations are to avoid routine supplemental oxygen therapy in suspected myocardial infarction unless the individual is hypoxic or in respiratory distress. Learn more about MyEMCert and key advances at www.abem.org.